So then we get to the question of access and cost and availability to our patients. As I mentioned, I work in a county healthcare system, a safety net hospital system in Parkland, and the system has determined that these medications, both the GLP-1 receptor agonists and SGLT2 inhibitors, are not only cost effective, but likely cost dominant when you're in a closed healthcare system. The complications avoided by the use of these drugs actually come close to or even pay for the cost that's been negotiating. Now, we probably get a cheaper per tablet or per dose cost because of the potency of our negotiation of such a large healthcare system. But in the open market, cost is a big deal and access is a big deal. There's prior authorizations required. It's a bit of a nuisance at times for physicians or providers to have to go through the steps to get prior authorizations. There's variable coverage by third-party payers, and of course, a lot of people have no insurance. And so navigating the cost around these remains a real important issue to work with the patients. But I do think cost efficiency should be formally reanalyzed. Initially, it was based on the glucose effects, and now that we have measurable clinical benefits, the cost efficiencies should be reassessed. But hopefully at the same time, as we have drug after drug and multiple drugs in each class, hopefully competition will take care of some of the pricing issues, and ideally we'll see some of these medications dropping in price and becoming more and more affordable and accessible. And of course, some of the SGLT2 inhibitors will fairly soon go off patent. I think in 2022 is the first generic SGLT2 inhibitor that we'll have. So cost is a big deal, but I think from a societal perspective, the potency of these drugs, especially SGLT2 inhibitors reducing heart failure, that's a real major impact on healthcare costs and healthcare utilization. So my suspicion is that we should be able to demonstrate relatively reasonable cost efficiency of these medications.